One of the challenges we have in healthcare is that we've create these dichotomies, and many of them are false dichotomies. Nurses versus doctors, patients versus the health system, everyone versus the insurance company. And I concluded the book with hopefully getting the reader to think in terms of a continuum.
Welcome to the Physician Growth Accelerator podcast, a show where we break down your private medical practice systems into vitals, give you the tools to diagnose root cause of what may be restricting your growth, and prescribe what to do about it. I'm your host, Zed Williamson, and I believe that everything any of us experience at any time is the perfect outcome of our current system. And the power in that statement is that we can take responsibility and decide if we want something different, then all we have to do is tweak the system. And system, a word that to me pretty quickly when I think of system is process. And process is a word that makes me think of our guest. So I'm very excited about our special guest today, Dr.
I'm
Douglas
Zed Williamson,
Slakey,
your host.
best-selling author
I've spent
of
the last couple
Process
decades
Manifesto,
studying human
improving
behavior
healthcare
and
in a
taking those
complex
learnings,
world.
working with
Doug,
hundreds
thank you
of
so much
private
for joining
medical
us today.
practices.
Oh, well, thank you for having me. It's a pleasure.
So I've already enjoyed our chat before I started hitting record. Your view on healthcare, how you got here, it's all very fascinating. And something that I would love for you to just jump into is what was the reason you took the time and put the effort in to write the book, The Process Manifesto? What was that charge that got you going?
The charge. Well, so sort of interesting. It really started, believe it or not, after Hurricane Katrina. So I was in New Orleans at the time, was the head of the transplant program at Tulane, and after Katrina was honored to serve as the chairman of surgery and did my part to rebuild healthcare in the Gulf South. And it was a little bit of a shift. I was still very busy in the operating room as a liver and kidney transplant surgeon. But it got me thinking about how do we improve access? How do we make our processes align with the realities of the post-Katrina world as things were fragmented and disjointed, and also gave us an opportunity to really think in some ways with a clean slate. And so I took that, developed a deep interest in high reliability theory, complex system management theory, and also how do we use those tools to optimize human performance on the front lines of healthcare. So that experience and knowledge wound up taking me around the world. And I was very blessed and fortunate to lecture to and help teams around the world improve their ability to care for patients. And so for years, people said, well, you've got to write a book about this. And so at the end of 2018, or 2023, sorry, it was just the right time to take a short sabbatical and sit down and put my thoughts together. And I really wanted to do it in a way that would be very easy to read, very straightforward, have real world experiences that I or others had gone through in dealing with patients, in dealing with the healthcare system, dealing with the sometimes tremendous bureaucracy that we all must navigate to try to provide the best care for our patients. And it's been really an interesting journey. It's sold now in 14 countries around the world and led to me being able to meet some amazing thought leaders and innovators and really think about how can we work together to improve the system in ways that allow people to flourish.
I love that. And one thing that I really appreciate about the structure is, well, first of all, I am a fan of books. I do like reading. And there are books that sometimes I read because I'm interested in the topic and maybe I'm going to learn some theory. Other books are prescriptive and I can actually implement things. And what I really like about the structure of yours is you discuss theory, but you're also giving tools that people can actually go and use so that it's a usable thing in their daily lives. So I really appreciate that approach to the book.
Well, thanks. Yeah, I really thought a lot about that actually, and to make it very practical and actionable. And then there's one particularly, I think, really interesting encounter, I guess I could say, that I had during the period of writing the book. So I was fortunate to have a number of people, read excerpts as I was putting it together. And one of them is a dear friend of mine named James Doty. He happens to be a neurosurgeon. He brought the Gamma knife to commercial use, and he then committed the rest of his career to compassion and altruism and supporting that in medicine. And in fact, he founded the Center for Compassion and Altruism Study at University of Stanford. And he was reading my book, and we were talking on the phone, and he said, "Well, Doug, you're always talking about compassion as being the foundational element of why people go into healthcare, and even moreover, why does healthcare actually exist?" And so I included that as the 10th principle in the book, was that every one of us, when we think about making healthcare better and how can we improve our ability to deliver care, we have to come back to that foundational element, which sometimes gets lost. And I'll add one other thing. As I was reflecting on it, as I was writing that final chapter, I really thought, one of the challenges we have in healthcare is that we've create these dichotomies, and many of them are false dichotomies. Nurses versus doctors, patients versus the health system, everyone versus the insurance company. And I concluded the book with hopefully getting the reader to think in terms of a continuum. The reality is that every one of us at some point in our lives will be a caregiver, and every one of us will be a patient. And so this idea of us versus them is really false. And one of the, I think, really important considerations I wanted to leave people thinking about as they do their part to improve the system is it's really about us. It's not us versus them.
Yeah, that's a great way to look at it. I heard you reference the idea that we're all part of a larger system and impacting the whole person health journey. Can you explain the distinction there, the whole person, why that matters?
Well, I think it's very important for us, particularly as healthcare professionals, doctors, nurses, others, that especially allopathic medical training, we're trained to focus on sick care. And we label the patient as a patient, and that presumes that the patient has a diagnosis that needs to be treated acutely. But the reality is, as people, we have a longitudinal healthcare journey, and we episodically interface with the system. But those are only small fractions of time. Really, our healthcare is much broader than that. And we know that there's good evidence in the literature that 60% or perhaps more of healthcare outcomes really are outside of our control. They're outside of the walls of our clinics, our hospitals, our ambulatory surgery centers, whatever the case might be. And we have to have processes and systems that recognize that and do something about the inevitable fragmentation that we've created. And so I like, especially when I'm teaching students and healthcare leaders and others, I really like them to think in terms of the person health journey instead of the patient health journey. It gets us thinking about how our contribution has to be considered yeah, as a part of a whole.
Yeah, I think that's important because the distinction really, I think, helps put a focus on it's easy for a practice to think about a patient when they're in front of them with a problem. And then they left with the practice or the surgeon or the physician, quote unquote, solving the problem. And that's not reality. right? And I actually, so I have a theory. I'd be curious what your thoughts are on this. So we work with private practices, and very commonly, private practices will have business frustrations. And sometimes you will hear people like, oh, doctors, surgeons, they don't make good business owners, which I think is silly. It's just not what that person was spending decades learning, right? They were learning anatomy. But also, um, in the medical space, you learn normal and you learn abnormal and you learn how to correct abnormal to normal. If you apply that same approach to business, it does not work because you are still dealing with all of the root causes. And I think that's kind of what you're touching on with the person compared to patient, because you can fix something, but if that patient goes home and lives a life that is creating a system that's going to unfix your fix, then it really wasn't fixed. And so I think that's, where these things kind of marry together. I don't know if that seems off base to you, but what are your thoughts?
No, I think that's exactly right. And it's so interesting. It works both ways. So, you think, and I know you deal mostly with private practices, but we're still increasingly, as physicians and healthcare providers, obligated to report results, right? And there's a lot of emphasis on risk sharing with payers. Well, one of the challenges there, if we don't recognize this longitudinal journey, the physician, the practice, the hospital, they can be held accountable for outcomes which are completely outside of their control. And that's not fair.
Yep.
Certainly. I think we all acknowledge that. But it creates tremendous challenges. It can create challenges where people will say, I'm just not going to offer care for that particular high risk person because at some level, I don't want to be accountable for those outcomes. We know we see that. It may be subconscious. I don't think anybody overtly, says I don't want to provide care, but we know that that's limiting. A great example, I was chief of surgery for Advocate Aurora for 27 hospitals in Chicago and Illinois. I was responsible for looking at value and high reliability. And we saw it, for example, with orthopedic surgery, where their low acuity patients, where did they do all those hips and knees? They did it in the ambulatory surgery center. And then when they wanted to operate on a patient with a BMI of 50, they would bring them to the hospital. And, that's some of it's due to resources, but some of it's also to minimize their exposure to those outcomes. So I think you're absolutely right. And I think when I advocate for process improvement, we need to really encourage people at all levels, including policymakers, to think more longitudinally and how do we better align information, actionable information, resources, and support to make that whole person health journey more seamless and to, at least from the patient's perspective or the person's perspective, reduce the fragmentation that they see and experience.
Do you, this may be a strange question, but do you ever feel like there's too much focus on the process and not enough focus on the process outcome?
Oh, yes, 100%. And I think there's sort of two elements to that. One is that we have to acknowledge and we have to teach people, especially some of our administrative colleagues, that patient care is complex. And if we try to be overly reductionist and reduce patient care to a very linear process, we're fooling ourselves. We're not recognizing individual variability and things from genetics to behavior to environment or culture or social determinants of health that are out of our control. So we have to appreciate complexity. And then the other component of that is that when we've tried to reduce healthcare to a very linear construct. Many of the key performance indicators, the KPIs that we use, are intra-process measures. Like, how long did a person sit in the waiting room? What was the room turnover time in the operating room? What was the length of stay in the hospital after they had their kidney transplant? Those may or may not, and unfortunately, those KPIs typically do not directly correlate with the patient outcome. And, we can see that. For example, since and I'm guilty of it myself. I've published a lot of papers and given a lot of talks, and one of the outcomes is length of stay after a surgical procedure. Look, I can do a laparoscopic living donor kidney transplant, and length of stay is 2.4 days instead of 5 days. And you say, great. But you know what? That hasn't translated to decreased per capita spend. In fact, we know our per capita spend in the United States is staggeringly high, and many times even other developed countries. And our life expectancy at birth is about 25th or 30th in the world. In fact, China eclipsed us recently on life expectancy of birth. So, we look at these performance metrics and they don't translate to outcomes in a consistent way, particularly from a patient perspective.
Yeah, that is so important. I think so many things get missed. First of all, I believe in measuring. And what our brain, if we go down to the neuroscience of our brain and what it looks for, the challenge with measuring is if we don't have a process to review what we're measuring and defining the hypothesis that we are supposedly using that information, our brain will take over, confirmation bias will jump in, and it's just going to use the data to support what we already believe. So someone who says 2.5 is better than 5, and then they see, oh, hey, we got 2.5. Oh, it's better. Oh, it's better? Yeah, it's better. Well, great, it's better. And it's not better. So I think it's such an important point in that we trick ourselves into correlation instead of causation, where we have all this data and we go, oh, well, it's better if this, but that's the old story that's always taught in business school is, sunscreen and ice cream.
Oh,
When you sell more sunscreen, you sell more ice cream. Well, that's correlation. Not you can't increase your ice cream sales by purposely selling more sunscreen. And I think in these KPIs that get measured, it's people are going off on these tangents. Confirmation bias is driving their focus, and like you said, it's not better.
no. And also, this may not be as much of an impact in an actual private practice setting, but I think they fall victim to this idea where, because of the fragmentation and silos we see in healthcare, a manager's focus tends to be on their isolated budget. And so, yeah, a great example, one of the papers we published, we looked at postoperative respiratory failure in one of our large hospitals, and it was clearly much higher than it should have been. And I won't bore you with the details, but what we identified as one of the causes was that pharmacy was restricting access to a medication that certain high-risk people really needed to reverse paralysis after the surgery. Now, not everyone needs that more expensive medication, but there's clearly a defined population. And we agreed on the population, but pharmacy was restricting it. The anesthesiologists were being held accountable for room turnover time. And that was part of their bonus structure for clinical incentive, we called it. So even if they knew that more expensive medicine was needed, the time it took to get it from the centralized pharmacy was um, created a conflict in the way that they looked at the outcome and their own personal accountability for room turnover time. So guess what happened? They didn't use that medication as often as they should have. The room turnover time metric, that KPI, was where people wanted it to be. But then on the other hand, we saw this increase in postoperative respiratory failure, which meant a lot of people who should have been going home were spending a day in the or two in the ICU on a respirator while the paralytic ran off. And so to your point, we have to make sure in healthcare uh, that we all agree on what are the ultimate driving principles and the outcomes which are superior to others. If you're running an airline, for example, your ultimate outcome has to be no airplane crashes, right? No one dies from an airplane crash. And if all the luggage isn't loaded and, 0.1% of bags are delayed, or something like that, well, then we have to accept those realities in our business model because our overarching quality metric has to be inviolate. We have to meet that.
It's this brings up a whole, you know, I believe that as humans, we're addicted to first order consequences.
Mm.
And if we're not paying attention to the second and third order consequences, then we can really make a lot of bad decisions. And that scenario you're talking about with the pharmacy, one way that a trick that we use, just because everything has a human component. So neuroscience is going to play a part in behavior and how people change things. But if we're ever working with somebody and they have something like what you describe, all you do is mentally imagine that patient's family member over your shoulder watching you high five someone over the KPI.
Yeah,
And what
right.
does that do? It instantly makes you go, well, that's not what we're here for. Okay, well, it's just that's really fascinating.
Well,
Uh,
and I'll just interject to add
yeah,
one thing. The other thing is, and this is, I think, something that probably really frustrates the people in private practice if they're going in and out of the hospital system, is they may not ever be aware of, in this example, the postoperative respiratory failure. They may not even know that happened.
yep,
And so, what happens then is, I think, and we see this with burnout, with learned helplessness, disenfranchisement. We've, uh, the administrative structures and the fragmentation and silos that we've created within our healthcare system have made it so that as a practitioner, even if you're motivated to do improvement, you may be so restricted in your ability to change things that you give up.
yeah, yeah. Speaking of not giving up, I'd love to shift the conversation, have you tell the audience about the HSSIC.
Yeah. Well, yeah, it's super exciting. So after I wrote the book and did a little consulting, I was looking for the next exciting thing to do. And I came to the conclusion that I had done enough surgeries to last a lifetime. That actually isn't easy especially for a surgeon, because our identity is so inextricably intertwined with what we do. But anyway, I made that decision. And so I moved to Nashville in July to help open a brand new medical school, the Frisk College of Medicine, which is really an exciting thing to do. We got our first class of students this fall. And I now have the privilege of chairing and leading the Department of Health System Science, which is a relatively new concept that we should be teaching people who are going into healthcare careers something about the systems in which they're going to be working. So everything from the business of medicine to understanding things like social determinants of health, leadership, communication, complex system, all these things, complex system management. So I lead the department, And I realized as I was thinking about what I was going to do in the role, that there was an amazing opportunity and actually a void in looking at innovative solutions. So, research, education, publications, how can we use education, leadership training, innovative technology and solutions to actually empower people and optimize performance on the front lines of healthcare, both on the healthcare professional and the patient side. So often we've looked at innovations in healthcare really sort of upstream from there. It may be, management of revenue cycle, as we talked about, the sort of linear process optimization. But what have we really done to help people do a better job and be able to work more effectively and efficiently and not be overburdened? So I'm super excited. We're starting basically a think tank, the Health System Science Innovation Collaborative, bringing people together. And I tell you, Zed, it's been amazing. It's resonated with stakeholders ranging from venture capital and private equity to large companies, Oracle Health, Stryker, and even big healthcare systems like HCA, which of course is in our backyard here. And the medical school has the Frist family name. So obviously we have a connection that we're really proud of with HCA here in Nashville. But yeah, very excited. We're really looking at how the value of this is how do we bring these stakeholders together to look through the lens of the front lines of healthcare and to create an environment where we can really help people do their jobs more effectively.
If, I'm guessing that there's some people listening to this right now where this has piqued their interest, the idea of this think tank. If they want to learn more information about that, what would you have them do?
Yeah, I think one of the easiest things is actually welcome to reach out to me on LinkedIn. That's a
Perfect.
great way, just Douglas Slakey on LinkedIn. Or they can look my email up at Belmont. It's just my uh, name, douglas.slakey@belmont.edu. But I would love to engage with any of your listeners and share ideas and practices. And I'll tell you, we in it's been interesting to me as I've socialized and shared this message, how many incredibly innovative people want to be part of the solution and want to help drive meaningful and positive change.
That's fantastic. We will put links to those in the show notes for easy access. And we will also put a link to so that someone can easily purchase the book, The Process Manifesto, Improving Healthcare in a Complex World. Doug, I really appreciate you taking the time and spending it with us today. Fantastic conversation. I'm really excited about the work that you're doing.
Well, thank you so much. It's been a pleasure, and I hope everyone has a great rest of the week.
Absolutely. And we'll see everyone next time on the Physician Growth Accelerator.